Hi there, I'm Dr. Brian Hill. I'm the director of the Lymphoid Malignancies program at the Cleveland Clinic, Taussig Cancer Institute. I'm here on behalf of the CLL Society to interview Dr. Susan Slager from the Mayo Clinic about some of the interesting work that she presented regarding CLL and CLL precursor conditions at the most recent meeting of the American Society of Hematology from 2021. Dr. Slager, welcome.
Thank you. Thank you for having me.
Great. So maybe you can also share with us some of the data. You had another presentation you alluded to, which was the relationship and susceptibility to serious infections in this and other precursor conditions. So maybe just tell us briefly about what MGUS is and what clonal hematopoiesis is.
Okay, well, thank you. Yeah, we had another abstract where we presented looking at the relationship of three precursor conditions or three other conditions, clonal hematopoiesis or CH, and then MBL or monoclonal B-cell lymphocytosis or MGUS, which is monoclonal gammopathy of unknown significance. MGUS is a precursor to multiple myeloma. Clonal hematopoiesis or CH has been shown to be associated with increased risk of myeloid leukemias. And there's some association with increased risk of lymphoid like CLL. And so we wanted to do the study is that there are three common conditions, and they are common in the elderly. The prevalence or the frequency of these conditions increases with age for all three of them. And so we wanted to look at, is there a relationship among these three conditions? And if you have multiple conditions, do you have an increased risk of getting infections? And so we screened about 400 individuals from our Mayo Clinic Biobank, again, for these three conditions. And we found that the prevalence was quite high, around 20% or so for MBL and 15% for MGUS and about 25% or so for clonal hematopoiesis. And so then we follow these individuals for, again, about nine years to look for increased risk of infections. And we found that what we've shown previously, if you have MBL, you have an increased risk of getting hospitalized due to infection. And we found that to be true with our MGUS, individuals that had MGUS. But for individuals that had clonal hematopoiesis, we didn't find any association of an increased risk of getting hospitalized due to infections. But then we wanted to ask the next question. It's like, okay, you have one, but what if you have more than one? So two or all three conditions. And we found that with a trend, as the number of these precursor conditions that you had an increased risk of getting infections. And so individuals with two of these conditions had about a 1.6-fold increased risk, and individuals with more than two conditions had a 2.6-fold increased risk. So there was a trend. Remarkably, one of the things we found in our study was that almost half of the individuals had one of these conditions. Now, our study is a little bit selected because of the MBL screening, but it's still pretty remarkable how common it was to have at least one.
Yeah. So, and again, this is a slightly older group of patients, right? Folks.
Yeah, adults that are about in their 60s.
Yeah. But in that group, you say about half of the patients had one of these three precursor conditions.
Exactly. Yes.
Okay. And just like in MBL, a number of patients can have MBL and never move on to the cutoff required for CLL. Is that also true for MGUS, moving on to multiple myeloma, and clonal hematopoiesis, moving on to acute leukemia?
Exactly. Yeah, so MGUS again is a precursor condition, but clonal hematopoiesis right now is just a risk factor. It means it increases your risk, but it doesn't mean you have to have it in order to get myeloid leukemias. But yes, you can have these conditions but never progress to any of these cancers.
Okay. So for all the 60-year-olds out there watching who have CLL, the fact that you may also have one of these other conditions doesn't necessarily mean that you need to be screened or tested or looked for it necessarily. Is that fair to say?
Yes, absolutely.
Okay. Yeah, because I think this, we get so many folks with CLL on active surveillance, watch and wait. And one of the frequent questions that we have discussions with in the clinic is, is there something else I should or could be doing? We know that there's a risk for skin cancer, for instance, in CLL patients, but you didn't find that MBL necessarily increased your risk of having MGUS or clonal hematopoiesis, correct?
That's correct. Yeah, we actually didn't find any association among those three conditions.
Got it. Excellent.
But we're still, the sample size is, it's only 500 people. And so we want to do a little bit. We have more samples that we're screening. So we'll get up to about 1,000 for the actual manuscript and to verify and really have good reliable data.
Got it. Wonderful. Excellent. Well, are there any other things that you'd like to kind of highlight or share with the audience on either of these observational studies?
Yeah, again, when participants contact me, not everybody will progress into these conditions, and not everybody will have these conditions. So I do a family study as well.
Yeah.
And even though
actually, if we have time, I know you've done a lot of work on familial CLL, and we have a couple minutes here. I could go off script a little bit maybe, because it's very interesting. If you look at the lymphoid malignancies, actually CLL has probably one of the highest preponderances of first-degree family members at risk. Right. And I have many patients in my clinic where I have two brothers and they both have CLL. I've got a lot of examples of that. Or I have a patient with CLL and I'm using males as an example because it tends to be males, but I've also have a mother-daughter or a mother-son who both have CLL, or one of them has a Waldenstrom's or an indolent lymphoma, and the other has CLL. So maybe could you share with the audience just a little bit about what you've found in your familial CLL study?
So we have found that individuals that come from these families, they do have a higher frequency of inheriting the genetic variants that increase your risk of getting CLL. So that supports the familial pattern that we see in these families. We have found that familial MBLs or familial CLLs have a same course as CLL patients that don't come from a family history background. We have found that individuals that are coming from these CLL families that have multiple members with CLL, they have a higher rate of MBL than what you see in the general population. And that we've recently published that these MBLs that come from these CLL families have about a 1 to 2% risk of progressing to CLL. And so that was the first time showing that individuals, especially low count MBLs, progressing to CLL. And so
is that higher than non-familial cases?
Well, it is, yeah. But we haven't published that data yet, but it is a higher rate. And there's no published results showing any low count MBLs in the general population progressing to CLL. But in our biobank, we're starting to see that. But the rate is much lower compared if you have a family history. Again, supporting that genetic contribution to your increased risk of getting CLL. Now,
in hereditary breast cancer, for instance, there's a gene test that's available, BRCA1, it's called, for hereditary when you have multiple family members with early or breast or ovarian cancer. Is there a test like that for CLL?
There is not yet, and there's no big important gene for CLL, but we're finding it's many. So to date, we've identified about over 40 inherited variants that are in your DNA that you get at birth. That increases your risk of getting CLL, and if you put them all together, we have a pretty good prediction of your risk of progressing to CLL. And so the question we really want to answer is, if you have MBL and you
Yeah.
come from a family and
Yeah.
we look at your genetic factors, what's your increased risk of progressing to CLL?
Mhm.
But those studies take a lot of time to wait and
For
get the
sure.
data.
Yeah. So what would you recommend to patients who have been diagnosed with CLL and they have another family member with CLL? Would you recommend that is there any role in the sort of clinical genetics screening for other family members to have any testing done? That's a question we get frequently.
Yeah. At this time, I wouldn't recommend screening any of the family members that haven't had, even for MBL. I wouldn't recommend doing the genetic screening or for screening it for MBL because there's nothing you can do about it. And, I'm finding it might cause a little bit more anxiety than what you would get knowing that knowledge.
Yeah.
But I'm finding it's different for everybody.
Yeah.
But that would be my recommendation.
Yeah. And that's, I think pretty consistent across the field of specialists in CLL. We're aware of the problem, but we don't have a tool. Again, there's no smoking gun gene to test for. A lot of this is probably multiple genes. And again, because it's a little different from early stage breast cancer, for instance, where there is an intervention that can be pursued, early mammograms, early MRIs, early surgeries. We don't do that in CLL. So I agree. I think that it's most appropriate just to have those family members be seen by their primary care doctor for regular checkups and pursue symptoms. But so that great. Well, I'm happy we're able to get that into this discussion as well. Thank you for all the work you do on behalf of CLL patients, and it was a pleasure talking to you.
Yeah, thank you very much. I really appreciate this.
All right, take care.
Bye-bye.
All right, bye-bye.